now to begin the presentation of the report.
Good morning, everyone, and thanks very much for coming. It's a pleasure to see so many faces and so many friends here. It's an honor for me to present this work on behalf of myself, Evan Wood, and the rest of the UHRI investigative team. What I'm going to do today is I'm going to describe the data from the Drug Situation in Vancouver report. This includes over 15 years of data from studies that we've been running for that period of time. I'm aware that some of you may not really enjoy looking at graphs and figures, but I'm going to do my best to explain the findings in plain language so that everyone can get the gist of what we're reporting on. I'm also going to try and place these findings within a local and a global context, and in doing so, what I'd like to do is I'd like to highlight the very gross discordance between reality, perception, and policy. There are many areas where the gap between the best available scientific evidence and policy and practice remains too great, and I know a few other areas where this problem is greater than in the response to problematic drug use. As many of you know, in the late 1990s, the Vancouver-Richmond Health Board declared a public health emergency in this neighborhood in response to the explosive epidemic of HIV infection that was occurring among people who inject drugs. At the same time, the province of British Columbia was dealing with a twin epidemic of fatal overdoses. In response to that, those twin epidemics, our group launched a series of studies to evaluate the HIV epidemic and the response to it. I'll briefly describe the sources of data that we'll be sharing today. Many of you are familiar with VITUS, the Vancouver Injection Drug User Study, which is now a cohort of over 1,000 individuals who inject drugs and who are HIV negative. VITUS has a sister cohort called ACCESS, which includes over 1,000 individuals who use drugs. We are also following over 1,000 street-involved youth, primarily in the downtown south area. And we are continuing to follow roughly 1,000 individuals who were randomly selected from Insight, Vancouver's supervised injection site, as part of that evaluation. Like much of the downtown east side, the gender distribution is a little more weighted towards males. About 67% of our cohort is male, 32% female, and about 1% transgendered. And in terms of the distribution of ethnicity and Aboriginal ancestry, about 63% report Caucasian ancestry, and as in the rest of the drug-using community, people of Aboriginal ancestry are overrepresented in our cohorts. Turning to housing, we've been tracking housing patterns over 15 years, and what this slide shows you is the blue bars represent the percentage of people who are reporting living in unstable housing. The green bars are single-room occupancy hotel living, and the yellow bars are homelessness. And as you can see, the level of unstable housing in this community has remained very high, although we've seen some recent declines in homelessness. I think there's cause to remain concerned about the housing situation for a variety of reasons, including the fact that our data here shows that people who live in unstable housing have much higher rates of HIV infection rates than those who live in stable housing. In terms of drug use patterns, there's been very large fluctuations in drug use patterns over the past 15 years, and in recent years there seems to be an overall decline in drug use. For example, when we look at the percentage of people who report injecting cocaine on a daily basis, you can see there's been a very, very substantial decline. However, this has been offset by a very substantial increase in the proportion of people who report crack cocaine smoking. However, if we look at the most recent years, since 2008, there has also been a decline in crack cocaine smoking. This is significant as well, given the fact that this decline in crack cocaine smoking actually occurred during a period when Vancouver Coastal Health dramatically increased the number of crack pipes that were distributed in this community. And this again is further evidence that when we respond with harm reduction programs and we provide people who use drugs with the supplies they need to use as safely as possible, we're not actually encouraging use. Again, what we've seen in Vancouver is actually a decline in crack use while the number of crack pipes were being distributed increase. Crack use remains certainly a concern for us. This is a paper led by Kerr in our group, who found that people who smoke cocaine on a frequent basis were at higher risk for HIV infection. So clearly there's more that we can do to respond. Among the things that our group has recommended is the establishment of supervised inhalation facilities so that people who smoke crack cocaine can enjoy many of the benefits that have been proven to exist for people who use Insight, Vancouver's supervised injection site. Inhalation rooms exist in Switzerland and other settings and have found to be very effective in engaging the crack smoking population. When we look at the percentage of people who report daily heroin injecting over the period, we also see a fairly substantial decline in heroin use. However, like with cocaine and crack, there has been some increase in the proportion of people who report injecting diverted prescription opiates. And certainly this is a cause for concern as well. We know that in the United States that overdose deaths have increased for 11 consecutive years, largely due to the misuse of prescription opiates. However, again, turning to the Vancouver data, while this is some cause for concern, when we look at the last 4 years, we see a very steady and significant decline in the proportion of people who report injecting prescription opiates. Another trend of interest is certainly the rise in crystal methamphetamine use. And while the prevalence of crystal methamphetamine use via smoking has declined in the recent 5-year period, the prevalence of crystal methamphetamine injecting has doubled recently, from about 5% in 2010 to about 10% in 2011. When we look at the patterns of drug use among street-involved youth, what you're looking at is a series of bars over different years between 2005 to 2011. The blue bar is the proportion of people reporting daily cocaine injection. The green bars are heroin injecting. The yellow bars are crack. The red bars are crystal meth smoked, and the orange bars are crystal meth inject. And as you can see from this slide, crack use remains very popular among street-involved youth. However, if you probably combine the crystal meth smoking and injecting, that would come out as the most popular drug. And one of the most notable trends is if you look at 2011, there's been quite a jump towards injecting crack cocaine. Turning to supply reduction, we know that throughout Canada and throughout the world there's been a continuing reliance on drug law enforcement as the primary response to problematic drug use, including efforts to reduce the use and supply of drugs. This has led to the widespread use of policing to try and control use and possession. And the Canadian Centre for Justice Statistics recently presented some statistics suggesting that the growth in policing has been really quite a booming business, if nothing else. This shows you the total growth in the number of police officers per 100,000 population. That's the black line. And the red line is the increase in expenditures on policing in the billions of dollars between 2000 to 2010, going from roughly around 182 billion to close to 200. As well, as many of you are aware, the federal government has also pursued a very get tough on crime approach, which has emphasized the punishment, control, and detention of people who use illicit drugs. And frequently we read in the media about stories about large-scale busts, and we hear the quotes of enforcement officials suggesting that there's been huge progress made in the war on drugs, such as this slide, where they claim to have chopped the head off a snake. So what about when we look at the data? Well, we see a slightly different picture. It seems that overall this approach has had minimal impact on the price of illicit drugs and their availability. What this slide shows you is the proportion of people who report being able to acquire crack, heroin, cocaine, pot, and crystal meth within 10 minutes. And as you can see, for example, in the case of crack, about 80% of people say they can acquire crack within 10 minutes, and it's also intriguing that it seems that crack, cocaine, and heroin are actually even more accessible than marijuana. When we look at the availability of prescription opiates, we can see that prescription opiates have actually become more available, although there's been a small decline in 2011, most likely related to the release of Oxy-Nu. Perhaps most striking, though, is the stability of prices on the street. The price of drugs from 2000 to 2011 have remained completely flat. So these data really suggest that the drugs on the street have really been largely unaffected by supply control and efforts, and including the implementation of the federal government's national anti-drug strategy. Turning to HIV, hepatitis C, risk behavior, infection, and the harm reduction response, I think it's important to be clear that while we hear throughout North America controversy around harm reduction programs, let's be clear, the United Nations and the World Health Organization understand the role that these types of programs play. They've issued a technical setting guide to guide countries in their efforts to control the spread of HIV among people who inject drugs. Their comprehensive package includes a set of several programs, including needle exchange programs and opiate substitution therapies, which fall under the harm reduction umbrella. However, in 2008, Cora de Beck, working with our group, conducted a fiscal analysis of Canada's national anti-drug strategy, and what did she find? That 70% of federal funds under the national strategy are dedicated towards enforcement and incarceration, while harm reduction receives only 2% of funding, prevention receives 4%, and treatment receives 17%. And of course, we continue to see headlines in some of our national newspapers, such as this one in the National Post, which just flatly declared that all harm reduction doesn't work. But when we look at HIV risk behavior, in particular syringe borrowing and syringe lending in Vancouver over the last 15 period, there is an absolutely dramatic decline in syringe borrowing and lending, which can largely be attributed to the expansion of harm reduction programs in the city, including those run by the Regional Health Authority, local community-based organizations, and the drug user community themselves. So just for example, 39.6% of people who use drugs reported syringe borrowing in 1996, but only 1.7% reported syringe borrowing in the last 6 months in 2011. And as indicated by the yellow bars in this slide, these declines in risk behavior have coincided with substantial declines in the number of people who are reporting that they're actually experiencing difficulty accessing syringes. So coverage has gone up, people have less barriers to access, and we see declines in syringe sharing. What is also very powerful is, as shown in this slide, the incidence of HIV and hepatitis C has also plummeted within the drug user community as a response to the harm reduction approach. Despite these substantial gains and a large body of evidence showing that programs like Insight have been effective in connecting people to addiction treatment and promoting cessation of drug use, the federal government has remained hostile to these types of programs and has recently attempted to do an end run around the Supreme Court decision allowing Insight to continue to operate. They have tabled Bill C-65, which forces municipalities to undergo a whole range of consultations with local community and police before they can open up a safe injection site, and essentially they put NIMBYism ahead of public health. And in case you're thinking it's just our group that is unhappy with this decision, I'd like to alert you to the fact that the Canadian Medical Association were very prompt in issuing a response to this bill, stating that they think that it's misguided and that the evidence shows that these facilities are an important part of the comprehensive response to drug use in the city. But there also remains problems in the media, and including there's a perception that somehow there's a bias in the response to addiction that greatly favors harm reduction over addiction treatment. However, if you actually look at the data on resource allocation, Vancouver Coastal Health continues to spend somewhere between 4 to 5 times as much as it does on addiction treatment as it does on harm reduction programming. But what does the data also say about addiction treatment? Well, if we look at the proportion of people entering addiction treatment, you can see there's been a huge increase. For example, in methadone maintenance therapy, we've seen an increase from about 11% of people reporting engaged in addiction treatment in 1996 to about 53% engaged in 2011. This has also been accompanied by a very positive trend in terms of people reporting having less problems with difficulty accessing addiction treatment. And when we look at other forms of treatment other than methadone, we see a similar trend of increasing treatment access. While addiction treatment and harm reduction programs have been expanding in the city, we've also seen a substantial number of people report that they've ceased injecting, with the greatest peak being in 2011, with 47% of people reporting that they ceased injecting in the last 6 months. This slide's a bit unusual because you'll see a drop in 2006, and that's really because we refreshed our cohort to make sure it was representative. We intentionally recruited a bunch of people who reported active injecting in the last 6 months, but as you can see, within a couple of years, the rate of cessation got back to the level it was in 2005. Unfortunately, mortality rates remain unacceptably high among the drug-using population in Vancouver. In 2008, mortality rates peaked at about 5.9 per deaths per 100 person years. However, our data suggests that these rates have since been declining. But it's important to note that these data also indicate that the rate of death among people who use drugs is approximately 8 times higher than that of the general population. So clearly, we've got a lot of work to do still. When we look at the probability of survival among people who are living with HIV versus those who are not, we can still see that people living with HIV are much more likely to die sooner than people who are HIV negative, and so we need to continue our efforts to promote treatment use, not only to prevent new infections, but also to promote survival among people affected by the epidemic locally. Violence also remains a concern in the city. This shows you different forms of violence between 2011, and it's notable that in 2011, about 15% of all people who use drugs reported experiencing some form of violence. And while reports of beatings and robberies declined in 2011 from 2005, the proportion of people reporting other forms of violence was consistently stable over the 6-year period, and there are obviously notable gender-based differences there as well. So, how do we interpret this data? Well, I think we certainly need to ask ourselves, is there time for a policy reorientation? We have continued to witness the federal government pursue a so-called anti-drug strategy, which greatly emphasizes things like enforcement, incarceration, but also a prevention program, which is really emphasizes the use of public service announcements to scare young people about the use of drugs. But what do we know about the effectiveness of such programs? Well, they've been rigorously evaluated in the United States. And not only have public service announcements been found to, in many cases, be completely ineffective, there is also a noted boomerang effect where prevention-type programs that try and educate and invoke fear often have the perverse effect of increasing drug use among vulnerable populations. Also concerning for us is the fact that when our group conducted a systematic review that looks at, well, what happens to drug market violence when you actually increase drug law enforcement spending? And what we found is that the study showed a uniform effect, that when you increase drug law enforcement, you try and crack down on drug users within drug markets, there's a parallel increase in drug market-related violence. And I think we have to also ask ourselves, is there any return on this investment at all? We know that in the United States, many states are now moving away from mandatory minimum sentences because very conservative states like Texas just simply can't afford to continue to incarcerate people for drugs. It's too expensive. But we're also concerned because work from our group has shown that people who are incarcerated typically have higher rates of high-risk syringe sharing within jails. And again, another nice piece of work by Cora DeBeck showed that when we looked at drug use patterns among people who have been incarcerated, people who are recently incarcerated were much less likely to stop drug use. So the cycle of incarceration is not only perpetuating HIV risk behavior and infection, but it's also perpetuating continued drug use, likely as a result of the trauma associated with incarceration. So what do we do? Well, a number of commentators, including the economists, are calling for a case for legalizing drugs. However, we look to some studies that show that there's quite a range of options between the current system of prohibition and full corporate profit legalization, and there's some evidence to suggest that when you regulate drugs under a public health model, that's when you experience the least amount of social problems associated with drug use. So in summary, we found large declines overall in illicit drug use, and even among the drugs where we've seen some increases in recent years, since 2007, the use of virtually every drug has declined, with the exception of some increases in injection crystal meth use. Crack cocaine remains the most commonly used drugs, whereas crystal meth use remains particularly high among street-involved youth. The availability of drugs remains high and price has remained completely stable. We've seen large declines in syringe sharing, HIV and hepatitis C, primarily as a response rooted in harm reduction and addiction treatment. And we've seen more people entering addiction treatment and stopping injecting. However, while we've seen some declines in mortality, preventable morbidity and mortality and violence are ongoing and remain concerns. So it seems that the health status of people who use drugs in the local community is improving. Harm reduction and addiction programs need to be continued to be scaled up, and they need to be tailored to the emerging needs and the drug use patterns that we've observed in this report. As well, given that there continues to be preventable morbidity and mortality associated with HIV infection, we need to continue to scale up HIV treatment efforts and HIV testing efforts to prevent new infections and to reduce morbidity and mortality. And we need to recognize the evidence from our center, which has shown that people who actively use drugs can successfully adhere to antiretroviral therapy, and active drug use is not a condition for refusing someone treatment for HIV disease. Our data suggests that the drug control efforts locally really have failed and resulted also in a problem of policy displacement, whereby we continue to place emphasis on an approach that's been shown to fail, and while we put our resources into this type of approach, other approaches remain dramatically underfunded and unsupported. We need to really reorient policy towards a public health-based approach. We need to expand the quantity and quality of harm reduction programs and community-based and drug user-based responses to the emerging problems in our communities. I'd like to conclude by first and foremost thanking very sincerely on behalf of all the UHR investigators, all the people who use drugs who participated in our research. I can't emphasize this enough. Many of members in the community and people in this room come to our office religiously every 6 months. They share with us personal details about their lives, things many of us would be unlikely to share with a stranger. But in sharing this information, they allow us to continue to document the situation here, to identify what's working and what's not, and to also provide some guidance for future responses. I'd like to also acknowledge the report co-authors, in addition to Evan and I, in particular Liam Ping T, who really took the lead in doing the report this year, Dan Werb, Cor DeBeck, Deborah Graham, and Peter Van, who helped with editing. I'd like to thank the staff and investigators with the UHRI, the BC Centre for Excellence, and UBC in particular, the communications team, Michaela Montana, and Lily T. and others and Kevin who helped organize this event, the many community groups who support this work, and our funders, the U.S. National Institutes of Drug Abuse and the Canadian Institutes for Health Research. If you want more information about our research and our program, you can get it at our website. One of the things we've tried to do to make our work more accessible to a broader population is we have a knowledge translation section, and if you're interested in a particular topic like housing or addiction treatment, you can go to that area. You will find citations to our research, and you can either look at the scientific summary or you can click on the plain language summary where the research is described in plain language in about 2 paragraphs, and that makes the research a little easier to understand. Thank you for your time and your attention. I appreciate it.